Welcome to this explainer. We're jumping straight into a high-yield clinical sprint today. We're going to take a massive chunk of head and neck pathologies and basically distill them down into quick, memorable diagnostic verdicts. Our goal? To lock these facts in so tightly that you'll pull them up instantly, even under intense clinical pressure. Let's do this. Okay, here's the quick agenda for today. First up, neck masses and malignancies. Then we hit salivary gland pathologies. And finally, ENT surgical emergencies. So, starting with Section 1, neck masses and malignancies, focusing heavily on the adult rule and a few other curveballs. Right, let's start with a classic vignette. Picture a 60-year-old male, heavy smoker, coming in with a 1.5 centimeter hard, fixed mass just below the angle of the mandible. He's had it for 4 months, no fever at all. What are we thinking? Thyroglossal duct cyst, dermatofibrosarcoma, infected branchial cyst, chemodectoma, or metastatic squamous cell carcinoma? Take a second to lock in your gut instinct. Okay, the verdict is E, metastatic squamous cell carcinoma. This is absolutely crucial. It's what we call the adult rule. If you see a hard, fixed mass in an older patient with a smoking history, it is metastatic SCC until you can definitively prove otherwise. That mass is likely a drainage basin for a primary cancer hiding in the tonsils or base of the tongue. Your absolute gold standard first move, FNAC, fine needle aspiration cytology. And here's the massive clinical trap. You must never, ever do an open biopsy on this mass first. No way. It disrupts the lymphatic planes and can literally ruin the field for a future radical neck dissection. The only time you'd ever use an open excisional biopsy as a rescue move is if you suspect lymphoma or TB and the initial FNAC completely fails. Now, what if the mass is lower down, specifically an enlarged node in the left supraclavicular basin? Well, that is Virchow's node. Think of this as a glaring systemic warning siren. Because of the way the thoracic duct drains, a mass right there tells you to stop looking at the neck and immediately start hunting below the clavicles. We're talking abdominal visceral malignancies, classically gastric adenocarcinoma, which is known as Troisier's sign. All right, let's move higher up into the skull base for this next one. A 40-year-old walks in with a gait disturbance. But the massive red flag here, they are having a really hard time understanding speech, and it's totally out of proportion to their actual pure tone hearing loss. So, what's expanding in there? Ham angioblastoma, meningioma, cerebral trauma, acoustic neuroma, or medulloblastoma? And the verdict is D, acoustic neuroma, also known as the vestibular schwannoma. It's a benign Schwann cell tumor sitting right on the vestibular branch of the 8th cranial nerve. And this perfectly illustrates how anatomy drives symptoms. As this tumor grows, it mechanically presses on the cochlear nerve, basically scrambling the brain's ability to decode complex auditory signals. That speech discrimination discrepancy is highly pathognomonic. Oh, and quick pearl, if you ever see bilateral acoustic neuromas, you are almost certainly looking at neurofibromatosis type 2. Let's do a really quick comparison of two very distinct neck masses that need totally different surgical approaches. On one side, the branchial cleft remnant usually pops up in kids right along the anterior border of the sternocleidomastoid muscle. The fix? You get to surgically excise the entire epithelialized tract. On the flip side, the chemodectoma or carotid body tumor. You'll see this in adults, especially those at high altitudes due to chronic hypoxia. It's a pulsatile mass vertically fixed to the carotid sheath. Now listen closely. Do not ever biopsy a chemodectoma. It is wildly hypervascular. A needle will cause catastrophic, uncontrollable hemorrhage. You fix it with a careful subadventitial dissection. Okay, shifting gears. Section 2, salivary gland pathologies. We're talking stones, swellings, and surgical anatomy. So let's run through a quick matrix of the parotid gland. If the swelling is acute, exquisitely painful, highly fluctuant, and spikes in pain every time they eat, that's a parotid abscess. Needs incision and drainage. But what if it's totally painless and firm? Probably a pleomorphic adenoma, the most common benign tumor here. You treat it with a superficial parotidectomy. Never just shell it out or it will rupture and spread. Finally, older male smoker with doughy bilateral masses? Think Warthin tumor. The absolute giveaway is that it's full of lymphoid tissue, meaning it shows up as a hot lesion on a technetium-99m scan. Speaking of salivary issues, let's talk obstruction. What's the best diagnostic imaging for finding a radiolucent calculus in a young patient suspected of having a parotid duct stone? Keep in mind the keyword radiolucent. Plain X-rays, MRI, CT, scilography, or salivary specimen analysis. The verdict is D, scilography.
Since parotid stones are mostly radiolucent, plain X-rays won't help you at all. We have to inject contrast directly into the duct to see the stone as a filling defect. And this brings us to the famous 80-20 rule, which perfectly explains this. 80% of all salivary stones happen in the submandibular gland, and 80% of those are rich in calcium, meaning they're radio-opaque and show up easily on plain film. But the parotid gland is the rebel. It only accounts for 20% of cases, and 80% of parotid stones are radiolucent. Now, if you do find a large submandibular stone, say greater than 4 millimeters, sitting deep at the proximal hilum near the third molar, you're in a surgical danger zone. You cannot just yank this out in the clinic under local anesthesia. You have to put the patient under general anesthesia so they are perfectly still. Why? Because the lingual nerve loops directly under Wharton's duct right there. One tiny slip of the scalpel and you've transected it, permanently robbing them of their sense of taste on that side. Definitely not something you want to risk.
All right, raising the stakes now. Section 3, ENT surgical emergencies, airway, anatomy, and action. Imagine this scenario. Patient comes in with a massive, rapidly expanding, deep neck abscess, something like Ludwig's angina. What life-threatening complication makes early surgical drainage absolutely mandatory? High fever, altered mental status, airway compression, rigors, or esophageal pressure. Basically, what's going to kill this patient in the next 5 minutes?
Verdict is C, compression of the airway. This is terrifyingly fast. The infection is trapped inside unyielding fascial planes, so as the pus and edema build, the swelling pushes the tongue superiorly and backward, straight into the throat. Death from Ludwig's angina is mostly caused by asphyxiation, not systemic septic shock. Because of this, your absolute first surgical priority isn't even the scalpel. It's securing the airway with an awake intubation or a tracheostomy before you decompress the infection. Moving over to the ear. A post-traumatic auricular hematoma is incredibly common in boxers or wrestlers. Blunt trauma shears the perichondrium right off the underlying cartilage. Here is the big anatomical trap. Ear cartilage is avascular. It relies entirely on that overlying perichondrium for its blood supply. If you leave the hematoma there, the cartilage literally starves to death and fibrosis into a permanent cauliflower ear deformity. And a quick needle aspiration isn't enough. The blood will just come right back. You have to formally incise it, drain the clot, and then sew a tight bolster pressure dressing to squeeze the perichondrium back onto the cartilage. For our final clinical scenario, let's look at a classic post-operative complication. Your patient just woke up from a total thyroidectomy. They are breathing perfectly normally, but their voice is suddenly incredibly hoarse. What specific anatomical structure got damaged? The external branch of the superior laryngeal nerve, recurrent laryngeal nerve, superior thyroid artery, inferior thyroid artery, or the parathyroid glands? It's B, the recurrent laryngeal nerve. If you injure one RLN, that vocal cord gets paralyzed in the paramedian or halfway position. It can't close fully, which causes the hoarseness, but the healthy cord can still open, so the airway is perfectly safe. Now, if you cut both RLNs, both cords slam shut in the midline, causing severe stridor and acute airway occlusion. Contrast that with the external laryngeal nerve. Injury there just means you lose cricothyroid tensioning. The airway is fine, no real hoarseness, but the patient literally cannot shout or hit high-pitched notes anymore, and their voice gets tired super easily.
All right, that is our clinical sprint recap. We've mapped out hidden primaries of neck masses, decoded the 80-20 rules of salivary stones, and locked in the airway first mandate for neck emergencies. So, taking this back to the real world, when your next patient walks through those clinic doors, literally grasping their throat in distress, which of these anatomical danger zones is your brain going to rule out first? Thanks for sticking with me on this explainer, and keep learning.